Hi, my name is Lana Schumacher, and I'm here today to discuss the surgical management of achalasia. I wanted to thank the course directors for their invitation to speak at the inaugural MINT in foregut disease program that we're having this year. So achalasia is generally diagnosed between the ages of 20 to 60 years old, with an incidence of about 1.6 per 100,000, so not very common. However, we commonly see it in our field, and it's due to the progressive degeneration of ganglion cells in the myenteric plexus, leading to a failure of relaxation of the lower esophageal sphincter and overall loss of peristalsis of the esophageal body. You can see here in this picture that where the myenteric plexus lives between the fibers of the longitudinal and circular muscular fibers of the esophagus. The gold standard is for diagnosis is high resolution manometry. So this just depicts a picture of what manometry looks like and the measurements that we're taking to assess the esophageal physiology. So we will have assessment of the gastroesophageal junction. We'll give measurements of the resting pressure, whether it's high or low. Does the esophagogastric junction relax with swallows? Is there a hiatal hernia? So all valuable information that we're gaining from the high resolution manometry. And then we can also assess the esophageal body response to wet swallows. So is there peristalsis? What's the amplitude, and are there spasms? So it's important to look at the integrated relaxation pressure to assess the EG relaxation. And when we look at this, we want the IRP to be less than 15. And we can also look at the distal contractile integral pressures, which normal ranges anywhere from 450 to 8,000 millimeters of mercury. And then we can also look at distal latency to look for premature esophageal body contractions and spasms. And so this is all important when we talk about achalasia. There's a specific classification known as the Chicago classification, which looks at the mean integrated relaxation pressure, which is greater than the upper limits, and that there's no peristalsis. This is for the classification of achalasia. And there's different types. We have the classic type 1, where there's 100% absent peristalsis with wet swallows. There's type 2, which is achalasia with compression, and there's panesophageal pressurization in greater than 20% of the wet swallows. And type 3 is a spastic type of achalasia, where you have premature contractions in over 20% of the swallows. And so this is a nice picture of the variations of the types of achalasia and the variation of pictures of manometry that you may find. And so you see in type 1, there's absolutely no color within that mid region, which is the contraction of the esophagus. And you have the higher resting pressure at the bottom. And in type 2, you see this pan pressurization throughout. And then type 3, you can see how there's the spasm of the pressures. However, no uniform contractions. So these subtypes can give criterion for the optimal treatment for achalasia. So type 2 is the most frequent form and has the best treatment response. And type 3 is the least common form and also has the worst treatment response. And it's least responsive to any pneumatic dilation and most responsive to Heller myotomies and POEM. So in diagnosing achalasia, it's important to think of the differential. Are there other dysmotility disorders of the esophagus? Is there a Schottky's ring, eosinophilic esophagitis, reflux esophagitis, infectious esophagitis, such as fungal esophagitis and malignancy? So getting the full testing and EGD included is helpful in the workup. And then we're here to discuss treatment options. So basically, you can do a mechanical disruption of the muscle fibers either by pneumatic dilation, surgical myotomy, POEM, and you can try biochemical reduction of the lower esophageal sphincters, which doesn't work as well or have durable response as far as the medications. So you can try oral nitrites and Botox injections. So today we're here to discuss the Heller myotomies, which is the surgical division of all the muscle layers of the lower esophageal sphincter and also extending into the esophageal body into the anterior gastric wall. And Ernest Heller first described this in 1913. He was a German surgeon, and he described both an anterior and posterior incision and performing the myotomy. In 1918, Groeneveld described a single incision as well as a gyrr. The laparoscopic Heller was first described in 1991 by Cucchieri, and Dr. Pellegrini described a thoracoscopic esophagomyotomy in 1992. So with what are the results? There's initial symptom relief in over 90% of the patients, and they showed similar outcomes between 12 to 36 months. And at mean follow-up at 19 months, there was about 30 plus patients that did have some dysphagia. However, looking at a large retrospective study in subsequent treatments comparing initial pneumatic dilation versus myotomy, there was a much more durable response and less dysphagia with the myotomy. And if we look at meta-analysis comparing pneumatic dilation with a myotomy, up to 1 year following the myotomy, it was more effective and associated with fewer adverse events. Now, there's other ways to do it. We can discuss doing a myotomy, either laparoscopic or robotic approach. So the nuances of robotic surgery is that we have better visualization with a 10x visualization in 3D and HD and smaller wristed instruments. So Dr. Kim actually looked at a study comparing standard laparoscopic techniques to the use of robotic Heller myotomy, and he compared patients in the laparoscopic group in a retrospective study and about 35 and 37 in each group, and the demographics, prior treatments, intraoperative complications, operative time, postoperative length of stay, and complications, as well as long-term results were compared. And the demographics between these patients were very similar. So in a univariate analysis, he found that the robotic group received longer myotomies than the laparoscopic group and had lower postoperative Eckert scores measuring dysphagia. And then there was a trend toward a lower incidence of recurrent Achalasia symptoms found in the robotic group, 0 versus 4, which was statistically significant. In the multivariate analysis, it also showed that a longer gastric myotomy was associated with lower recurrence rate seen in the robotic group. And this is to show that the follow-up time and time to recurrence, if you looked at the laparoscopic group versus the Heller myotomy group. This is another study by Domani that was an analysis of 14 studies looking at laparoscopic versus robotic. And they noted that the mucosal injury was about 5 to 15% in the laparoscopic group. And in looking at the Heller myotomy group, there was significantly lower incidence, almost 0 of esophageal perforation. I think this just goes to the fact that you can see so well and have wristed instruments to do fine dissection. Now, how does POEM fare compared to the laparoscopic Heller myotomy? Dr. Patty looked at this in a meta-analysis of 53 laparoscopic Heller myotomy studies versus 21 studies for the POEM group, and looked at main outcomes measuring improvement of dysphagia and postoperative GERD. That is one of the discussions of a laparoscopic Heller versus a POEM. So the results show that the mean follow-up was significantly longer in the laparoscopic Heller group than the POEM group, but there was improvement in dysphagia at 12 months for the POEM group at 93% versus 91% for the laparoscopic Heller. And At 24 months, this was a pretty durable response of improvement of symptoms at 92% for the POEM and 90% for the laparoscopic Heller. But most importantly, to look at the POEM group were more likely to develop GERD symptoms, and they had statistically increased evidence of erosive esophagitis, as well as GERD with pH monitoring. And the length of stay was about 1 day longer. So their conclusions was that the short-term results of POEM was more effective than laparoscopic Heller, or was associated with a higher incidence of pathologic reflux. And so more recently, this study published in 2020 by Ming Kim's group looked at robotic and POEM versus laparoscopic Heller myotomy and looked at all the complications. And this was a retrospective review of the patients with achalasia undergoing laparoscopic Heller, robotic Heller, or POEM between the years of 2013 to 17. And the laparoscopic Heller myotomy group had significantly higher combined technical complications compared to the robotic group and the POEM group. And these were mainly as perforations and conversions that were noted in that. So when we discuss how to do this procedure, you can look at these two examples. Are a port placement for a robotic approach on the left side of the screen and a laparoscopic group. So similar port placement. And I think in deciding, the steps of the myotomy is going to be the same, whether you do it laparoscopic or robotic. You want to identify the right pillar of the crus, the posterior vagus. You want to divide the phrenoesophageal membrane and identify the anterior vagus, and as well as the left pillar of the crus, and divide the short gastrix and expose the gastroesophageal junction. You want to ensure that you have the correct position of the myotomy on the anterior surface and extend at least 6 centimeters above the gastroesophageal junction, and at least 2.5 centimeters onto the wall, so that your myotomy is about 8.5 centimeters in length. This just depicts an example of this. And then I think what we showed earlier in the data is that, it is important to do a partial fundoplication to try to prevent reflux. And usually most surgeons will pick either what's called a door fundoplication, which is a 180-degree fundoplication, versus a 270-degree fundoplication, which is called a toupee. So here's a video of a robotic Heller myotomy. Let's start by taking down the gastrohepatic ligament, doing the hiatal dissection, taking off the phrenoesophageal ligament, entering into the mediastinum. And the advantage, I think, of robotics is that you can really get high in the mediastinum, mobilize that esophagus to create a very long myotomy. We'll divide the short gastrix to prepare for the fundoplication at the end of this case. And then check that we have enough mobilization. And then I think importantly is to dissect off the fat pad. This allows us to really see the gastroesophageal junction to create that myotomy on the stomach. We want to mobilize the vagus so we can work around this. And then we can create our myotomy. We'll start right on the esophagus above the G junction. We can start by either just slowly pulling those fibers apart, getting both the longitudinal, the muscle fibers apart to get us right down onto the submucosal plane. Once visualizing that plane, then we'll use our harmonic scalpel. You can also use a bipolar or other instruments to divide the muscle fibers. We'll just keep dissecting in that plane. You can see that submucosal plane very well. See all the muscle fibers. I think that's a great advantage of the robotic approach, is the visualization. And here you can see each fiber, and we're showing that we're going now onto the stomach across the gastroesophageal junction. We're slowly dividing these fibers. Instead of pulling them, you can also switch back to sometimes a cautery. We want to see that we're scoping the patient to check for a leak, but also to check that all of those fibers are divided. Once we're happy with our extension onto the stomach, we'll create our fundoplication. Here's a door fundoplications, which is 180-degree anterior fundoplication. Again, we're not doing a full fundoplication because the fact that there is no peristalsis within that esophageal body, a patient wouldn't have profound dysphagia if they had a full fundoplication. So this is tacking at 180 degrees over to the right crus and left crus and frontoesophageal ligament to create our fundoplication. And once this is performed, we ensure there's no tension on that fundoplication. Another advantage I feel with a robotic approach, because we have smaller wristed instruments and we can see so well, even in cases such as this gentleman with a hepatomegaly, there was concern he wouldn't be able to get to the gastroesophageal junction and hiatus to do a redo Heller myotomy. This was a 51-year-old gentleman with a history of type 1 achalasia who had a laparoscopic Heller myotomy and door fundoplication about 10 years ago. He had recurrent dysphagia with vomiting and regurgitation and weight loss. And he had a manometry consistent with achalasia versus pseudo-achalasia. Was there a herniation of the wrap? So we discussed, should this patient undergo a redo myotomy via a robotic or laparoscopic approach or a POEM? I think that because of the question of the herniation of the wrap, we felt it would benefit to explore him via robotic approach, and felt that we could easily deal with the liver in this situation. And so this is just a quick video clip of that, and to show that we had no problem with the liver. This is important to take down the whole fundoplication. And it's pretty easy to deal with adhesions and redo surgery with a robotic approach. Again, small wristed instruments allow for finer dissection. Is also the visualization being so good that we're magnified and have both 3D and HD visualization. It allows for a very safe redo approach. So we're mobilizing this esophagus, again, dense adhesions everywhere, which we expected in a redo case, taking down the full fundoplication so we can really see the gastroesophageal junction, and then performing a more posterior myotomy as the patient already had an anterior myotomy, and getting right down to that submucosal plane. Here's mobilizing the vagus. Again, this is a bipolar instrument performing the myotomy instead of a harmonic scalpel. I think there's an advantage in redo cases when there's more adhesions. And then just continuing this onto the stomach. So we just use a video to show the benefits of sometimes having enhanced visualization and wristed instruments in challenging cases, and performing a long myotomy or scoping the patient at this point, and ensuring that that's nice and wide open, and then checking for leaks. So key points to consider when dealing with achalasia from a surgical standpoint. You always want to your contrast esophagograms should show the bird's beak appearance of the gastroesophageal junction without delayed emptying of the stomach. You commonly see the aperistalsis in the distal third of the esophagus with incomplete relaxation. High resolution manometry is key in diagnosing achalasia and the different subtypes, showing an elevated median integrated relaxation pressure and aperistalsis. And it's always important to add the EGD to look for masquerading pathology. And just know that patients do have a slightly increased risk for cancer, which is low, but surveillance is not recommended. And then to consider the key surgical therapy points for a Heller myotomy is that you want to also include a partial fundoplication. I think that's kind of the benefit that we've seen to deal with the reflux after a Heller myotomy that is seen in the POEM group. The robotic Heller myotomy appears to have a benefit over the laparoscopic Heller myotomy, but randomized trials have not been performed to this date comparing the two, as well as comparisons between a robotic, laparoscopic, and POEM procedure has not had a randomized trial, but just looking at retrospective retrospective data that we've shown that there's less complications in the robotic Heller myotomy group and POEM group over the laparoscopic Heller myotomy. Again, the instances of reflux seem to be higher in the POEM group. Both pneumatic balloon dilation and Botox initially have high success rates, but patients have a more frequent relapse, and medical therapy is often ineffective. So to end the talk, I wanted to thank again the course directors for the invitation. Please contact me if you should have any questions. Thank you.